So I want you to imagine two completely identical patients. They both suffer a TIA, a mini stroke, and their imaging shows they both have the exact same 70% blockage in their carotid artery.
Right, exact same clinical picture.
Exactly. And they are scheduled for the exact same surgery by the exact same surgeon. But patient A basically has their stroke risk virtually eliminated. Patient B gets almost zero clinical benefit. And the only difference between them, the calendar.
Yeah, it's wild. It completely upends how we usually think about medicine, right? I mean, we tend to focus so much on the mechanics of a procedure or like the molecular structure of a drug.
Right, focusing on exactly what is given to the patient.
Exactly. But with secondary stroke prevention, this temporal dimension, just this strict adherence to biological timelines, it dictates the entire efficacy of the treatment.
Well, welcome to today's deep dive. We are unpacking a massive medical case file and the accompanying clinical guidelines to really figure out the precise science here. Because surviving that acute phase of an ischemic event, it's a massive victory. But once the patient stabilizes, the mission shifts entirely.
Yeah, it's a lot like putting out a house fire. The acute phase is the firefighters putting out the flames. But today's deep dive, this is about the fire inspector coming in afterward, rewiring the whole house so it never sparks again.
I love that analogy. And to figure out how to rewire the house, we have a huge stack of trial data to get through. We need to determine exactly what is given to a patient to stop a recurrence, but maybe more importantly, exactly when it's given.
Right, because the overarching theme in these sources is that secondary prevention is a masterclass in timing. You can't just throw the kitchen sink of, blood thinners at a patient and hope for the best.
Because the risk profile is dynamic, right?
Right.
It changes from day 1 to day 21 to day 90.
Oh, wildly. Yeah, the biological environment is constantly shifting.
So let's start with day 1, the immediate aftermath. The patient is stabilized. When we look at exactly what is given on that first day, we almost always see aspirin or clopidogrel.
Yeah, antiplatelet therapy is really the baseline. If you start aspirin within 48 hours, the data shows it reduces the combined risk of stroke, myocardial infarction, and vascular death by roughly 25%.
25% is huge for something sitting in most people's medicine cabinets.
It really is. And clopidogrel operates as a slightly superior alternative, honestly. It has a better gastrointestinal bleeding profile, so it's tolerated a bit better.
Okay, but here is where human intuition gets us into trouble. Because logically, you'd think, well, if blocking platelets with one drug reduces the risk by 25%, why not use two? Like, let's hit the platelets from two different angles.
Right, the more is better approach. And the medical community tested that exact hypothesis extensively. It's called dual antiplatelet therapy, or DAPT, which is combining aspirin and clopidogrel.
And it works, right? At least initially.
It does. The CHANCE and POINT trials proved that DAPT is exceptionally effective at blunting that acute spike in recurrence. You're simultaneously blocking the CLX1 pathway with aspirin and the P2Y12 receptor with clopidogrel.
Heavy suppression.
Right when the patient's endothelium is in its most highly thrombogenic state. So if you start it within 24 hours for a minor stroke or a high-risk TIA, it's fantastic.
But there is a massive trap here in the guideline.
A huge trap, yeah. Because human intuition tells us, hey, if this two-drug regimen is keeping a catastrophic event at bay, don't change the plan. Just keep them on DIPT indefinitely.
Be safe.
Exactly. But the MATCH and SPS3 trials showed that keeping patients on dual therapy long-term is actually incredibly dangerous.
Wait, really? It actually gets worse?
Yeah. Prolonged DFTT provides absolutely zero additional ischemic benefit over single-agent therapy, but it meaningfully increases the rate of major hemorrhage. In one of the trials, extending that dual therapy actually drove up all-cause mortality. The ischemic benefit is entirely front-loaded, where the bleeding risk just builds up cumulatively.
I think of this like hiring two really aggressive bouncers for a nightclub right after a massive brawl.
Oh, that's a perfect way to look at it.
Right. For the first few weeks, the threat environment is volatile. You absolutely need those bouncers to keep the peace. But if you keep those same two hyper-aggressive guys on payroll for months, long after the initial threat is gone, they get restless.
They do.
The environment has stabilized, but their aggressive protocol hasn't, so they just start breaking the furniture themselves.
That analogy perfectly mirrors the underlying biology. Because the ruptured plaque that caused the initial event, it begins to heal and endothelialize over those first few weeks. As that physical substrate stabilizes, the thrombotic drive naturally drops.
So if you maintain maximum platelet inhibition after that healing happens, you're just asking for trouble.
Exactly. The lack of coagulation leads to spontaneous microbleeds elsewhere in the vasculature, which gives us the hard 21-day clinical cliff.
Okay, so the golden rule here is DAPT is strictly a 21-day window. Exactly what is given has to change precisely at 3 weeks. The patient has to transition back to monotherapy.
That's the rule.
That is such a clear, actionable takeaway for localized vessel threats. But let's shift gears a bit. What happens when the origin of the clot isn't a local endothelial rupture, but systemic? Like specifically when the patient has non-valvular atrial fibrillation.
Oh, that completely changes the antithrombotic strategy. When the atria fibrillate, instead of contracting smoothly, blood pools in the left atrial appendage. It sits there, it stagnates, and it forms a large, robust clot.
Which eventually just gets pumped directly up into the cerebral circulation.
Exactly. And standard antiplatelets are largely ineffective here. Aspirin only reduces stroke risk in AFib by about 21%.
Because the composition of the clot is fundamentally different, right?
Right. A local vessel clot is platelet-rich, what we call a white clot, driven by shear stress. But a clot formed by stasis in the heart is fibrin-rich, a red clot.
So targeting platelets is just the wrong biological mechanism entirely.
Precisely. You need oral anticoagulation to target the coagulation cascade itself. The standard of care has aggressively shifted to DOACs, so direct oral anticoagulants.
These are drugs like apixaban, rivaroxaban, dabigatran.
Yes. They reduce stroke risk in AFib by roughly 68%, which is massive compared to the 21% with aspirin. And they've largely supplanted warfarin because they have a significantly lower rate of intracranial hemorrhage.
Okay, a 68% reduction is undeniable.
Right.
But looking at the administration timeline, this is where the guidelines present what looks to me like a terrifying paradox.
How so?
Well, we just established that AFib creates these massive, dangerous clots. Yet, if a patient suffers a major ischemic stroke from AFib, the protocol strictly forbids giving them a DOAC immediately. You generally have to wait at least 6 days.
You do.
Leaving a high-risk AFib patient totally unprotected for nearly a week just seems deeply counterintuitive. Aren't they at the highest risk for another stroke?
They are, and it's an agonizing calculation for the neurologist. But it is entirely dictated by the phenomenon of hemorrhagic transformation.
Which is what, exactly?
When a major ischemic event occurs, a large territory of brain tissue infarcts. It dies. The blood vessels within that necrotic zone lose their structural integrity. They become incredibly friable and weak.
Oh, I see. So if you introduce a heavy-duty blood thinner while the local vessels in the brain are essentially disintegrating?
The normal arterial pressure will just blow those weakened walls right open.
Yeah.
The intervention would transform a stable ischemic infarct into a catastrophic intraparenchymal hemorrhage.
Wow. So you are literally forced to withhold the DOAC, accepting the systemic risk of a second clot, simply to allow the infarcted tissue in the brain enough time to structurally stabilize.
Exactly, and the timeline scales with the severity. For a TIA, you can start the DOAC at 48 hours once bleeding is ruled out. But for massive strokes, you might have to wait well beyond a week.
That perfectly highlights the danger of just throwing the heaviest artillery at a problem without understanding the environment first. Which actually brings us to one of the most interesting failures in recent clinical history, I think, the ESIS trials.
Ah, yes, embolic stroke of undetermined source.
Right. So a patient presents with a stroke that looks radiographically identical to a cardioembolic event. It looks like a classic traveling clot. But exhaustive workups reveal zero AFib.
And the assumption for years was that these were just cases of occult AFib, like paroxysmal fibrillation that our monitors simply failed to catch while they were in the hospital.
So logic suggests that if it looks like an embolic clot, and DOACs are our most powerful weapon against embolic clots, we should just deploy them. I mean, even if we can't catch the AFib on an EKG, why not blanket the ESIS patients with a DOAC just to be safe?
And the Navigate ESIS trial testing rivaroxaban and the Respect ESIS trial testing dabigatran, they operated on that exact logic. Both trials were massive, highly anticipated, and they both completely failed.
Wait, completely failed? Like they found no benefit at all?
The DOACs provided absolutely no superior ischemic protection over standard aspirin, but they predictably drove up the rates of major bleeding.
So the heavy security caused collateral damage without actually neutralizing the threat. Biologically, why did that happen? If the clot traveled, why didn't the anticoagulant work?
The trials forced a really harsh realization for the medical community. Not all embolic strokes are hidden AFib. The term ESIS was masking a highly heterogeneous group of pathologies.
Like what else could it be?
Well, some of those traveling clots originated from complex aortic arch atherosclerosis. Others were paradoxical emboli crossing through a patent form and oval, a hole in the heart.
Oh, meaning those clots were likely platelet-driven? White clots from structural shear stress, not fibrin-driven red clots from cardiac stasis.
Exactly the issue. By blindly applying a DOAC, we were targeting the totally wrong coagulation pathway for a significant portion of those patients. It reinforces the central thesis here. Precision diagnosis dictates the therapy.
Escalating to a stronger drug class without confirming the specific mechanism is clinically reckless.
It really is.
Okay, so we've covered the viscosity of the blood and the specific composition of the clots. But when looking at exactly what is given to the patient upon discharge, there is also a massive emphasis on treating the physical vasculature itself, the metabolic engine driving the risk.
Lipid management is a non-negotiable pillar here. The landmark Sparsal trial radically shifted how we view statins in neurology. It demonstrated that administering atorvastatin significantly reduces stroke recurrence in patients with a prior stroke, or TIA, totally independent of their coronary disease status.
And the targets are aggressive. The current guidance demands a statin for all ischemic stroke or TIA patients, pushing LDL below 70 for those with established atherosclerotic disease.
If max statins don't hit the target, they add ezetimibe or PCSK9 inhibitors. They push hard for those numbers, yeah.
But if we are looking at the mechanism, a patient who just had a stroke doesn't have time to wait for decades of plaque regression. How is a lipid-lowering drug protecting them in the short term?
The magic of statins lies in their pleiotropic effects. We track them by their ability to lower LDL, sure, but their immediate protective benefit comes from endothelial stabilization. Statins rapidly decrease inflammation within the vessel wall.
Oh, so it's a structural benefit right away.
Exactly. They thicken the fibrous cap over existing atherosclerotic plaques, making those plaques far less likely to rupture and trigger a new platelet cascade.
They're essentially applying molecular mortar to the compromised walls. That's incredible. And speaking of protecting the walls, that transitions perfectly into the final pharmaceutical pillar: blood pressure.
The sheer impact of blood pressure control in these sources is just staggering.
The guidelines target a systolic under 130 and a diastolic under 80, usually using a thiazide diuretic, an ACE inhibitor, or an ARB, right?
Right. And the data reveals that a seemingly marginal reduction dropping the systolic pressure by just 10 to 12 points and the diastolic by 5 to 6 points translates to roughly a 38% reduction in stroke incidence.
Wait, really? Because we hear modest reduction and think modest results. A 10-point drop sounds like nothing. You could probably induce a 10-point swing just by having a stressful conversation.
I know, it sounds like a rounding error on a standard blood pressure cuff.
Exactly. A 38% risk reduction implies a highly nonlinear relationship between pressure and vascular damage. How does such a minor adjustment yield that much of a clinical outcome?
Think about the physics of shear stress. The vascular system isn't a collection of static pipes. It is a dynamic high-pressure network.
Kind of like a municipal water grid. If you have a compromised retaining wall in a main reservoir, dropping the total water pressure by even a fraction fundamentally changes the turbulent kinetic energy smashing against that weak spot.
That is precisely what is happening at the endothelial layer. Hypertension creates continuous mechanical trauma against the arterial walls. It accelerates plaque formation and increases the likelihood of rupture.
So dropping the systolic pressure by just 10 points significantly reduces the mechanical shear stress on those newly stabilized plaques.
Yeah.
It stops the microfractures from propagating.
Exactly. It drastically lowers the risk of a secondary event.
Which perfectly sets up our final, most invasive intervention. We've optimized the blood viscosity, we've stabilized the plaque chemically, and we've lowered the physical shear stress. But what if the structural weak point is already a massive physical barrier? We are talking about symptomatic carotid stenosis.
Right. When a patient has a 70 to 99% atherosclerotic blockage in the carotid artery causing ischemic symptoms, medical management alone is just insufficient. Revascularization is required.
And the CRUST trial extensively compared the two primary surgical options for this, right?
Yes. Carotid endarterectomy, which is the open surgical removal of the plaque, versus carotid artery stenting.
And the outcomes were broadly comparable, though they carry different risk profiles during the procedure. Stenting involves navigating wires through the aortic arch, so it carries a slightly higher risk of procedural stroke from dislodging debris.
Right, while the endarterectomy is an open surgery that often requires cross-clamping of the artery, so it puts more stress on the cardiovascular system. That yields a slightly higher risk of periprocedural myocardial infarction.
So the choice of procedure is highly individualized based on the patient. However, the most critical takeaway from the surgical guidelines brings us directly back to the very first statistic we discussed in this deep dive, the 25-fold rule of timing.
The pattern of the day. Let's unpack that.
Okay, patient A and patient B, both with symptomatic 70% stenosis.
So patient A received the endarterectomy within 2 weeks of their index TIA. The number needed to treat, which is the statistical metric of how many patients you must operate on to prevent one major stroke, is 5.
So it's an incredibly powerful, highly justified intervention.
Extremely effective.
Yeah.
But patient B undergoes the exact same surgery by the same surgeon, but the procedure is delayed beyond 12 weeks. The number needed to treat skyrockets to 125.
That is a 25-fold difference in effectiveness, driven entirely by the calendar, not the scalpel. Why does the calendar dictate the efficacy so aggressively?
Because of the natural history of an unstable plaque. The period of maximum instability, the time when the plaque is most actively throwing off microemboli, is in the immediate aftermath of the initial symptom.
So if you wait 12 weeks,
One of two things has already happened. Either the plaque is fully ruptured and caused a massive devastating stroke, or the plaque has naturally scarred over and stabilized.
so operating at 12 weeks is just exposing the patient to the inherent risks of open surgery to fix a threat that has largely already neutralized itself. You're closing the barn door 3 months after the horse bolted.
Exactly. Timing isn't just a detail in medicine, it is often the majority of the treatment effect itself.
It beautifully synthesizes everything in this case file. So looking at the comprehensive discharge plan, exactly what is given to the patient, we see a highly orchestrated timeline.
We do.
Yep.
Our patient will wait exactly 6 days before starting a DOAC to balance the AFib risk against hemorrhagic transformation. They are loaded on a high-intensity statin to instantly stabilize the endothelium and an ACE inhibitor to drop that shear stress by that magical 10 points.
The acute emergency room interventions save the life in the moment. But this rigorous, intellectually demanding secondary prevention protocol is what dictates the quality and longevity of the decades that follow.
It requires an absolute rejection of medical autopilot.
It really does. And as we wrap up our analysis of these guidelines, I want to leave you with a thought regarding the future of that precise timing. We often think that in health and medicine, doing more is the safest route. Taking the medication longer, adding more interventions to be on the safe side.
The human instinct to overprotect.
Exactly. But as this deep dive shows, that instinct to overprotect can be the very thing that harms us. Sometimes the most important and difficult medical decision isn't knowing how to start a treatment, but having the discipline to know exactly when to stop.
A critical lesson.
And it makes you wonder about where this is all heading. Throughout this deep dive, we've leaned heavily on generalized population-level rules. We cut off DAPT at exactly 21 days. We wait 6 days for a DOAC. We rush surgery within 2 weeks.
Right, but those are blunt statistical averages.
Applied to highly unique human biologies. Consider the trajectory of personalized medicine and artificial intelligence. We are rapidly approaching an era where wearable sensors and real-time biomarker analysis could continuously map a patient's coagulation cascade.
Oh, that would completely redefine the field.
Imagine a future where we don't rely on a rigid 21-day clinical cliff. Instead, an AI model analyzes the exact molecular stability of your personal endothelium and alerts your physician at day 18, hour 4, that your individual risk profile has officially crossed the threshold from clotting to bleeding.
That is fascinating.
The masterclass in timing we studied today might just be the crude, early foundation for a future, where secondary prevention is dictated not by a generalized calendar, but by the hyper-personalized biological clock ticking inside your own vessels. Something for you to mull over as you review the latest in vascular neurology. We'll catch you on the next deep dive.